here in the United States, most patients were getting antibiotics at some point during their hospitalization. I think that it's very difficult, particularly when you're learning about a disease for the first time, to know whether this is the right thing or wrong thing to do. But when you have patients who are very sick in front of you, you want to do everything you can do to help them. What the NIH guidelines would tell us is that in patients who come in for their original presentation to the hospital with concern for COVID-19 or proven COVID-19, if there is suspicion for sepsis or bacterial co-infection at that time, that antibiotics should be started on those patients. For patients who have prolonged hospitalizations and remain in the ICU for days, if not weeks at a time, we get into a different realm of infections, and these are hospital-associated infections, and these are the infections that are most likely to be highly resistant or resistant to different antibiotics. And such infections include ventilator-associated pneumonia, skin and soft tissue infections, or bloodstream infections associated with central lines, or urinary tract infections associated with catheters. The opportunity to learn about this disease was quite short. So we were really relying on our known pathophysiology and complications of other viral infections. And particularly, we were relying on the experiences dating back to 1918 with influenza. And what we know about influenza is that there's a high rate of bacterial co-infection, particularly Staph aureus and Streptococcus, and that many of the patients who had influenza died from bacterial co-infection. The reason that we wanted to do this is that currently the antibiotic pipeline is lacking innovation. It's not currently sustainable, and the current reimbursement models rely on reimbursement of sales or volume-based sales of these different antibiotics. And the concern is that drug companies are leaving this space because of the low overall number of infections that would need new drugs. And because of that, the antibiotic pipeline is kind of dwindling away. The main conclusion of our study is that the current volume-based sales revenue strategies that are used to sustain the antibiotic market are not sustainable, and that we're going to have to come up with innovative ways to reinvigorate the antibiotic pipeline. What we really want to do is make sure that we stay ahead of the game with the development of novel antibiotics with new mechanisms of action and be one step ahead of the bacteria, because the bacteria are always mutating, acquiring other resistance mechanisms that will lead to antibiotic resistance, and there's no way of stopping that. What we can do is be prepared, have an innovative pipeline, have novel mechanism antibiotics, and be one step ahead of the bacteria.